We have now seen two excellent programs in pulmonary rehabilitation in two different settings, one in the Denver metropolitan area at the Lutheran Center and one in Little Company of Mary Hospital in Torrance, California. Both are well equipped and well positioned to offer the very latest care to the patients that are referred to these programs. Rich and I have been working together in trying to complete a major textbook on principles and practice of pulmonary rehabilitation. We captured the science pretty well, and we captured some of the practicalities. But there are many more things going on, and I'd like you to bring us up to date on the cutting edge of science in this field.
Well, Tom, the new thrust in pulmonary rehabilitation is to try to calibrate the program to the individual. And this has really been brought home. I just returned from an NIH workshop that was specifically set up to define the new areas of research needed in pulmonary rehabilitation. And the point is that we need better instruments, better devices, better methods to assess our patients. We need to have quality of life measures. We need to better define how and why pulmonary rehabilitation prolongs survival. We need to define how much and in what way pulmonary rehabilitation decreases hospitalization. Our research has been focused on finding ways to increase exercise tolerance in patients with chronic obstructive pulmonary disease. These patients are limited by shortness of breath when they exercise. One of the constant features of pulmonary rehabilitation programs across the country is an exercise program. We're investigating new ways to design exercise programs to maximize their benefit. Most patients with lung disease become very sedentary. They experience dyspnea with minimal activity. One of the goals of pulmonary rehabilitation is to help patients realize that a little shortness of breath is not necessarily harmful. Their sedentary behavior also leads to another problem. The leg muscles become very deconditioned. We know from studies on healthy subjects that exercise programs can reverse this. The muscles actually increase in size and are able to utilize the oxygen delivered to them more efficiently. In our exercise laboratory, we observe the physiologic responses to exercise in patients undergoing rehabilitation. By measuring the responses before and after the program, we can determine why exercise tolerance increases. Our first patient is Mrs. Joan Tafilsky. Ms. Tafilsky came to us about a year ago. At that time, her FEV1 was about 20% predicted, and her diffusing capacity was about 30% predicted. As we're all well aware, lung function does not change as a result of pulmonary rehabilitation. But in our physiologic assessment of her exercise capacity, we can see why her exercise tolerance of everyday activities has improved. Before rehabilitation, in an incremental exercise protocol, she was able to tolerate only 16 watts. Afterwards, her tolerance improved to 29 watts. In a constant work rate protocol, she tolerated 4 minutes of exercise before rehabilitation and 15 minutes without any difficulty after rehabilitation. Importantly, when we compared her level of ventilation and heart rate at equivalent levels of exercise, they both fell, which in part explains why the exercise tolerance improved. Our second patient, Mr. John Ard, is a 65-year-old man. He too had severely impaired lung function. His FEV1 was 20% predicted, and his diffusing capacity was 30% predicted. In an incremental exercise test, he tolerated 9 watts before and 23 watts after rehabilitation. In a constant work rate test at 5 watts, he tolerated 4 minutes before and 15 minutes after without any difficulty. For an equivalent level of exercise, his ventilation was 27 liters per minute before and 16 liters per minute after. His heart rate was 120 beats per minute before and 106 beats per minute after, demonstrating that the physiologic stress of the exercise had decreased. We feel this is due to more efficient utilization of oxygen by the exercising muscles.
Well, Tom, I really enjoyed showing off our laboratory over at Harbor UCLA. We've really started working very hard with a number of collaborations, not only with the people in Denver and in Los Angeles, but people around the world who who are interested in this sort of approach to pulmonary rehabilitation?
I think that's right on, Rich. Pulmonary rehabilitation, as you have seen, is something that is marvelous for people who want to do more than just receive ordinary care for their chronic respiratory disorder. I look at pulmonary rehabilitation in a sense as preventive care. It prevents and forestalls premature morbidity and mortality, and more importantly, returns patients to a feeling of enjoyable life. You have viewed two excellent programs that show how practical pulmonary rehabilitation can be. It amazes me that people are still asking, is it wise to start a pulmonary rehabilitation program? Is it cost effective? How do you get started? I think you have seen the answers to these questions, and I'm just delighted that we can look upon the field before us as something where pulmonary rehabilitation will truly be the standard of care for all patients with chronic respiratory disorders.